Diagnosing a developing mind requires a departure from the logic used in adult psychiatry. The standard adult model relies on a static diagnostic framework. A specific set of persistent symptoms aligns with a defined disorder. This logic collapses when applied to a child, whose baseline state is one of constant developmental flux. Their cognitive and emotional parameters are never fixed. Neurobehavior in early life is not a self-contained or preset unfolding of genetics. It is embedded in the bidirectional regulatory processes between the child and their caregivers. Because the patient is a moving target, clinicians utilize a highly structured assessment architecture to separate true pathology from normal developmental turbulence. This rigor is necessary to resolve diagnostic ambiguity, identify medical comorbidities, manage pharmacological risks, and evaluate immediate safety. To map this complexity, clinicians use the triangulation matrix, a multi-source data collection process. No single metric or solitary informant can be trusted in isolation. Reliable data must converge from the child, the family, and the broader environment. This triangulated data is passed through a biopsychosocial filter. Biological systems sit at the center, influenced by expanding layers of psychological and social factors. A symptom like inattention radiates outward from cellular biochemistry to the physical and psychosocial worlds, manifesting differently at each level. This multi-vector approach provides the only viable path to a reliable clinical hypothesis. The first vector of the matrix is the direct clinical assessment of the child. While parents offer essential observations, children and adolescents are often the most accurate informants for internalizing symptoms, mood or anxiety states that caregivers frequently miss. The primary tool for this vector is the Mental State Examination, or MSE. The MSE evaluates the child's appearance, their attitude toward the clinician, and their baseline mood and affect. It analyzes the rate and volume of their speech while screening their thought processes for structural abnormalities. Finally, the clinician checks for perceptual disturbances and evaluates the child's level of insight into their own condition. These findings must be calibrated against the patient's cognitive and psychological development, which may differ from their physical maturity. Extracting this data requires balancing the child's individual autonomy and confidentiality against mandatory safety protocols. The MSE provides a snapshot of the child's internal world, but this snapshot requires historical context to hold clinical value. For that context, clinicians turn to the second vector, the parents or primary caregivers. Caregivers provide the longitudinal data necessary to establish the timeline and duration of the presenting problem. This involves tracing prenatal experiences, medical history, and early infant attachment relationships. The clinician also maps the wider family system, screening for parental mental illness or familial trauma that may be shaping the child's environment. During these interviews, clinicians must avoid being drawn into secrets between family members, which can compromise the assessment's objectivity. This history acts as the longitudinal anchor, revealing whether a behavior is a sudden deviation or a lifelong pattern. The final raw data vector is the child's broader system, specifically the school environment. Clinical validity in child psychiatry requires pervasiveness. A symptom must be observed across multiple, distinct environments. Severe behavioral problems confined to a single classroom suggest a situational stressor, whereas a pervasive disorder manifests across different social settings. To gather this data objectively, clinicians deploy structured observational tools and standardized reports. In a suspected ADHD case, for instance, clinicians use the Conners rating scales from teachers to verify symptoms outside the home. Systemic data separates contextual misbehavior from genuine cross-contextual psychological impairment. Once the three vectors of data are collected, they are passed through specialized, operationalized diagnostic filters. Semi-structured interviews like the K-sets are used to disentangle complex mood and anxiety presentations. Structured schedules, specifically the ADIR and the ADOS-G, are required to isolate autism spectrum disorders from generic social difficulties. Yet, even with these specialized filters in place, the assessment requires a medical override, a strict pause to check for underlying physiological causes. An unreported acquired brain injury can perfectly mimic the impulsivity and oppositional behavior associated with psychiatric disorders. Physical examinations and baseline investigations are mandatory, especially before starting psychopharmacological treatments like methylphenidate or risperidone. Child psychiatry is a diagnosis of exclusion. The biological hardware must be cleared before the psychological software is confirmed. This process culminates in the formulation, a comprehensive multi-axial explanation that transcends simple DSM-5 or ICD-11 billing codes. The formulation provides a blueprint of the child's pathology and environment. It determines if a symptom is statistically abnormal relative to the child's specific age, gender, and cultural background. To reach a diagnosis, the formulation must also prove functional impairment, demonstrating that the symptom actively damages the child's everyday life. Impairment is measured by 4 criteria: interference with development, social restriction, personal distress, and a negative effect on others. Without meeting these criteria, the findings represent a personality trait or a developmental phase, not a psychiatric disorder. The formulation transforms raw behavioral data into a precise, actionable clinical roadmap. This roadmap dictates the specific type and scale of the clinical intervention required. A formulation confirming pervasive anxiety with social restriction points directly toward a stepped psychological intervention. In this scenario, cognitive behavioral therapy, or CBT, is the direct consequence of the assessment. CBT specifically targets the cognitive distortions and negative self-talk identified during the child's mental state examination. Child psychiatric assessment functions as an active, triangulated process of testable hypothesis generation. By systematically mapping the developing mind through a biopsychosocial lens, clinicians engineer the specific architecture required for a child's recovery.